So let's look at the first question. So this one says a 32-year-old lady presents to the infertility clinic. She has regular cycles of 28 days. Ovulation can be confirmed with which? Okay, so we all know that when we talk about ovulation, we will do it, or the serum progesterone levels, yes, they should be done 7 days before the expected date of menses. That's the best answer. Okay, and if we take a 28-day cycle, this turns out to be day 21. But please remember that it has to be 7 days before the expected date of menses, right? So here the answer would be serum progesterone levels on day 21. Please remember this is one of the easiest and a reliable test of ovulation, right? And quite commonly done as well. And when it comes to the most accurate method, yes, so then, you know, either we talk about histopathology or we talk about transvaginal ultrasound for follicular monitoring. Yes. And when we talk about serum progesterone levels on day 21, values which are more than 3 nanograms per ml indicate that the cycle is ovulatory. What else we can easily do is urinary LH kits. Yes, and these kits are going to measure the LH surge. But please remember they measure the LH surge in the urine and not in the serum. So here the answer is that this would be positive 24 hours before ovulation. Okay, so this would be positive 24 hours before ovulation. Please remember when you talk about in general LH surge, that is the serum surge which happens 36 hours before ovulation. So don't get confused between the two things, okay? Right, let's go on to question number 2. Now, the fluid used for hysteroscopic polypectomy using bipolar cautery. So you have to understand when you talk about bipolar cautery, we can use both, electrolyte deficient media as well as electrolyte rich media. We can use both, yes, with bipolar cautery. When it comes to unipolar cautery, we can only use electrolyte deficient media. Yes, and I'm sure you remember the examples. The electrolyte deficient are, glycine, sorbitol, mannitol. Yes, these are electrolyte deficient, so 1.5%, right, 3% and 5% mannitol. Electrolyte rich are ringer lactate and normal saline. We can use 5% dextrose in the electrolyte deficient media as well. Now, when we talk about bipolar, we can use both electrolyte deficient and electrolyte rich media, but what are we going to prefer? We are going to prefer the electrolyte rich media, so that even if there is a lot of fluid absorption, there is no electrolyte imbalance. Yes, so that is why the preferred answer here is going to be normal saline. Yes, now please remember both types of medias can be absorbed and can cause fluid overload, right? So they both can cause fluid overload, but when you talk about fluid overload, it is more dangerous with electrolyte deficient media because it will lead to electrolyte imbalance. So the upper limit at which, so if there is a fluid overload of 1000 ml or 1 liter, you have to halt or stop the procedure. Whereas with electrolyte rich media, this cutoff is 2.5 liters or 2500 ml. If the patient has absorbed this much fluid, then you're going to halt the procedure, because after that, even this becomes quite dangerous, right? Okay, let's look at the next question. So the next question says, your patient undergoes multiple maternal serum screening at 16 weeks of pregnancy. Her serum alpha fetoprotein turns out to be raised. So what is raised? If it is more than or equal to 2 to 2.5 multiples of median, that is considered as raised. The patient is extremely concerned and she comes to your office for additional counseling. What would you want to tell her? Right? Now, please remember one of the most common reasons for abnormal maternal serum alpha fetoprotein levels, right, is whether it is high or it is low, it is going to be wrong dates. Yes, so the first thing is that you have to confirm this, right? And along with that, you have to look out for increased alpha fetoprotein reasons, right? Which you know could be multiple congenital malformations, right? It could be neurological, it could be anterior abdominal wall, right? And therefore we say once the levels of alpha fetoprotein are raised, right, even if they're found to be decreased, the first thing that you should do is ultrasound. So the answer here is B. The ultrasound should be performed to confirm the age as well as to rule out fetal anomalies. Now, there are many causes of raised AFP, so I don't want you to remember that. I want you to remember causes of reduced alpha fetoprotein levels. So these are in maternal trisomies, gestational trophoblastic disease, maternal diabetes, right, maternal obesity, right? So these are some of the important reasons, and wrong dates I've already mentioned. These are one of the important reasons of reduced alpha fetoprotein levels. So this is a much shorter list, easier to remember. Remember this, right? Various anomalies can cause raised levels of alpha fetoprotein. And the ideal time to measure maternal serum alpha fetoprotein is 16 to 18 weeks. Please remember, when you talk about raised AFP, one of the important implications is to find out whether the baby has neural tube defects. And again, for that, what you should do is do an ultrasound. So do an anomaly scan to look for detailed anatomy of the baby. Okay. Let's go on to the next question. So a patient comes to you in the office because she has just missed her periods. Her home UPT is positive. And she's extremely worried because she's had a barium enema done last week, right? The patient is concerned regarding the deleterious effect of radiation exposure on the fetus. Now, I'm sure you all know that barium enema, yes, there is a significant higher radiation as compared to a chest X-ray or a pelvic X-ray. But please remember, even this single exposure of a barium enema, right? So exposure of radiation of a single diagnostic study is usually not associated with increased risk of teratogenicity. Now please remember, once the radiation dose exceeds 5 rads, okay, or we say 0.05 grays, right? This is what is considered as the limit where some effects may start to happen, right? Now beyond 10 grays, okay, so beyond 10 rads, sorry, and 0.1 gray, right? Beyond this, there are definite effects on the fetus in terms of malformation, in terms of growth restriction, in terms of, intellectual disability, right? So these, beyond this, there is definite effect. So beyond 10 rads or 0.1 gray, right? Now between 5, so beyond 5 rads and up to 10 rads, this is called as the gray zone. Yes, this is actually the gray zone, where they say that some effects may start to happen, but obvious effects would happen beyond 10 rads or 0.1 gray. As long as the radiation dose is less than 5 rads or 0.05 grays, there is no deleterious effect on the fetus, right? So this single barium enema does not necessitate any kind of intervention as of now, right? So the other statements are wrong, as I have explained. Option A says there are definitive fetal effects at doses less than 5 rads. No, this is a false statement, right? Single radiation exposure like a barium enema results in radiation dose that will be significantly toxic to the baby. No, it won't, right? Increased risk of mental retardation when radiation exposure occurs at less than 8 weeks. No. So this is also important. Please remember, it is between 8 to 15 weeks that the fetus is most radiosensitive in terms of risk of mental retardation or intellectual disability, right? So this is when the fetus is most radiosensitive for intellectual disability or mental retardation. So the answer here is going to be C. Okay. The next one is simple. At what stage of embryonic development will embryo most likely implant? So this is going to be a blastocyst. So implantation happens in the form of blastocyst. Blastocyst is formed on day 5, and this is post-fertilization. Whereas please remember that implantation will begin on day 6. Yes, so implantation begins on day 6. It is completed by approximately day 10, right? And it happens in the form of blastocyst. The most common site, I am sure you all remember, it is the upper posterior wall. Do not mark the fundus. And at the time of implantation, there may be bleeding, which is what is called as Hartmann's sign. Hartmann's sign is nothing but the sign for implantation bleeding. And the implantation is going to be eccentric in the uterine cavity. So it will be either in the right or on the left side, but not in the center of the cavity. So the implantation is eccentric, and that's why you can elicit the Pisca 6 sign. Yes, which is unequal growth of the uterus because of eccentric implantation, right? Let's look at the next question. Your patient is undergoing an elective repeat cesarean section. The infant is delivered without any difficulty, but the placenta cannot be removed because a clear plane between the placenta and the uterine wall cannot be identified, right? The placenta is removed in pieces. This will be followed by atony and hemorrhage. Now, what is this clinical situation? So this is a classical description on how adherent placenta, especially if it is a accreta, will present. Right, so accreta, increta and percreta are 3 forms of adherent placenta, out of which the most common one is placenta accreta. Right, so this is a typical description how it will clinically present, and I want you to know this description because the question could come the other way around as well. Sometimes, we will ask you to match clinical descriptions to the present, to the diagnosis. So this is how you have to do it, and this is what you have to know about it. Okay. Now, as far as adherent placenta is concerned, I am sure you remember that the classic histopath finding is absent neta box membrane. And here there is no intervening decidua between the placenta and the myometrium. So the intervening decidua is absent. Also, the highest risk factor is placenta previa in a patient with previous cesarean section. Yes, so this is what carries the highest risk. So if a lady has placenta previa and she's also a case of previous cesarean section. Yes, placenta previa by itself is also a risk factor. Even if there is no previous cesarean, this by itself is a risk factor for adherent placenta. Yes, please remember, the treatment of choice for adherent placenta is a cesarean hysterectomy. And also remember that the investigation of choice is going to be ultrasound. Yes, the classic finding is placental lacunae. You will see placental lakes or lacunae. Yes, and along with this, there will be loss of bladder line. So what is bladder line? Bladder line is the thin space between the bladder and the myometrium. So if it is an adherent placenta, sometimes this bladder line will be absent, depending on how deep the placenta is going. Okay. If some of you are wondering what is a fenestrated placenta, so nothing special. A fenestrated placenta is a placenta where the central portion of the placenta is missing. So there will be no cotyledons there. On either side there will be cotyledons, but the central part of the placenta is missing. That's what is a fenestrated placenta. The other two you all know. So succenturiata is an additional lobe which is much smaller than the main lobe, and it is attached to the main lobe by the vessels, and the cord will be attached to the main lobe. That's a succenturiata. Previa you all know, placenta in the lower segment reaching the os is what is placenta previa, right? Okay. Let's see. Which of the following neoplasms has been associated with the use of oral contraceptives? The safest answer here is hepatic adenoma. Yes, as far as ovarian cancer is concerned, the incidence is decreased. With, hepatic cancer, there is no association. Yes, and breast cancer, generally we also say there is no association, especially if you talk about low dose pills. High dose pills, yes, do increase. So if somebody is currently using high dose pills, they will increase the risk of breast cancer, but not usually with the low dose pills. Having said that, please remember a known breast cancer is an absolute contraindication for OCPs. But, so that you don't get confused in your main exams, but if we say a lady has BRCA mutation positive or she has a family history of breast cancer, can she use OCPs? Yes. Yes, so here OCP use are safe. Right? So also please remember, as far as endometrial cancer, OCPs are going to reduce the risk. Colon cancer, again OCPs are going to reduce the risk. Cervical cancer, there is a slight increase in risk, which is dose dependent and duration dependent. So this will happen only if she uses OCPs continuously for a span of more than 5 years. Okay. Now, which of the following is the best explanation for the mechanism of action of copper intrauterine devices? The answer is D. So there is an inflammatory response within the endometrium which kills the sperms. Yes, right. So this inflammatory response is what is the a foreign body reaction. Basically, is the reason of the inflammatory response. Right, and this foreign body reaction is toxic to the sperms. It does affect the sperm morphology, the sperm motility, even sperm capacitation, phagocytosis, all these are affected, and therefore implantation and fertilization is inhibited. So inhibition of implantation because of this local reaction, right? That is the main mechanism of action for intrauterine devices. Even for Mirena, this will be the main mechanism of action, right? Although there will be additional effects of a Mirena because of the presence of progesterone, but the main answer will remain the same. Okay. Now, please remember, when it comes to the intrauterine devices, remember the absolute contraindications. Okay. So these are a severe distortion of the uterine cavity, active pelvic infection, not a past infection, I'm saying an active pelvic infection, a suspected pregnancy, yes, then unexplained abnormal bleeding, Wilson's disease will definitely be an absolute contraindication for copper device. Breast cancer will be an absolute contraindication for Mirena, but not for a copper device. Yes. Please remember, previous history of ectopic is not an absolute contraindication. Nulliparity is not a contraindication. This is where students do land up making mistakes. Okay. Let's look at the next question. A patient at 32 weeks presents for her routine obstetric visit. She has no problem, but her blood pressure is 150/96. Dipstick is 2+. She complains of a constant headache and vision changes that are not relieved by pain, by a pain reliever and rest, right? Then you send her and you see that her blood pressure is 160/106 at a tertiary care center. What is the next step? So if you see this patient has all signs of impending eclampsia, right? So headache, which is often described as the worst headache, visual changes, epigastric pain, yes, sudden onset of dyspnea or breathlessness, which may tell about pulmonary edema. These are all features of impending eclampsia. And here the first and the most important thing is to prevent the seizure. There is no doubt she needs a blood pressure control as well. But if we talk about the next best step, it has to be magnesium sulfate, right? You have to prevent the seizure or from her going into eclampsia because that worsens the prognosis. Yes, she will need antihypertensive therapy as well, okay? And the drug of choice would be labetalol. And because her blood pressure is more than or equal to 160 systolic, although diastolic is 106, right? She would need IV labetalol. That is going to be the drug of choice. If that's not available, the second line is going to be hydralazine, right? But out of the two, the first thing that we want to do is ensure that she does not throw a seizure. So magnesium sulfate is the drug of choice, and it acts on the NMDA receptors on the brain. It acts by causing cerebral vasodilatation, right? So, you know, the reason for seizure is cerebral hypoxia and cerebral edema. So, it also causes cerebral vasodilatation. So, it is the drug of choice, right, in cases of to prevent impending eclampsia, and this patient would also need termination of pregnancy. So, impending eclampsia is an indication to do termination of pregnancy. So, once you settle the patient, control the blood pressure, give Maxalf, we will also start, you know, the process of delivery for this patient. So, for her, the preferred mode is going to be vaginal delivery. So, we'll also induce labor. But as of now, the next most important step is prevention of seizures. Okay. Now, a couple presents for evaluation of primary infertility. Evaluation of the woman is normal. Husband has a left varicocele, right? What would you expect the findings on semen analysis? So these are going to be a decrease in the sperm count as well as abnormal morphology. Yes, because the local temperature is raised in the scrotum, which affects the process of spermatogenesis, right? Now, please remember, when we talk about male factor infertility, yes, the most common reason is defective spermatogenesis. So, primary testicular defects, so defective spermatogenesis. Yes, so that is the most common reason. And this is called as primary testicular defect, because the defect is at the level of the testes itself, right? So, primary hypogonadism. Right? And yes, I'm sure you all know that the varicoceles are more common on the left side, and that's because the left, testicular vein drains into the left renal vein, and it drains at an angle of 90 degrees. So varicoceles are generally more common on the left side. Okay. Next, your patient is at 40 weeks. She has history of 2 previous uncomplicated vaginal deliveries. After 15 minutes of pushing, the baby's head delivers spontaneously, but then retracts back towards the perineum. And if you remember, this is what is the turtle sign. When the head retracts back towards the perineum, that's the turtle sign. So, as you can see, we've already given you in the question that the anterior shoulder fails to deliver. So, yes, we are dealing with shoulder dystocia. Yes. So now, what is the next step? So the first thing that you have to do, apart from call for help, which is not here in the answer. So the first thing is that you must call for help. And by the time the call for help comes, you must empty the bladder. Yes, give a liberal episiotomy, right? And then what do? You are going to do a sudden flexion of maternal legs. So we have to do a sudden flexion and abduction of the maternal thigh on the maternal abdomen. Yes, this is what is the Mac-Roberts maneuver, which is the first maneuver we do in terms of shoulder dystocia. What does this do? This causes, a movement of the symphysis pubis in a cephalad manner. So, symphysis pubis moves cephalad, and as a result of which, the available space in the epidiameter increases. If Mac-Roberts maneuver alone fails, then what else do? You will also then give, along with Mac-Roberts, a suprapubic pressure. So please remember, suprapubic pressure alone or the first thing is not done. First you do Mac-Roberts. If that fails, then you do Mac-Roberts with suprapubic. Okay? Zavanelli is actually the last maneuver. Right, so Zavanelli is the last maneuver we do for shoulder dystocia. Okay, let's go on to the next question. Your patient undergoes a primary cesarean delivery under regional analgesia for malpresentation at 37 weeks. After delivery of the placenta, the anesthesiologist look at the classic finding, notes seizure activity with profound hypoxia, hypotension. They intubate the patient, provide the circulatory support with vasopressors, but then there is massive hemorrhage from the surgical sites, right? What is the likely cause? Now, this is again a very classical description of amniotic fluid Embolism. Isko yaad kar lo. When you see such a condition, that is a sudden cardiovascular collapse, right, along with hypoxia and hemorrhage in a laboring patient or a patient who is immediate postpartum, you should think of AFE, amniotic fluid embolism, right? So most of the times it will happen during labor or within 30 minutes of delivery, right? Right, so that is amniotic fluid embolism, and it classically leads on to DIC, right? And that's the reason why the patient is bleeding from all the surgical sites. So this is the classical description. It has a high mortality rate, and it is one of the causes of DIC, but please remember that AFI is a rare thing to happen. It's not a very common thing to happen. And that is why we say that if a lady develops unexplained shock after delivery, that's when you think of amniotic fluid embolism, right? So unexplained shock after delivery, you should think of amniotic fluid embolism. It is rare. It is a diagnosis of exclusion, right? Okay, a 32-year-old patient delivers a stillborn fetus at 34 weeks, right? And the placenta is noted to be much larger than normal. The fetus appears to be hydropic, and there is petechiae. What is the most likely causative agent? So I've underlined the keywords for you. So a stillbirth. Which infection leads to stillbirths? I'll come to it. Which infection causes a large placenta? Yes? And it also causes the fetus to be hydropic. So the answer here is syphilis or Treponema pallidum, right? Now please remember, this stillbirths is very characteristic history of syphilis. If you have gone through my lectures, we've always taught you that with syphilis what happens? Every subsequent pregnancy goes to a longer gestation. So it may be an early abortion, then stillbirth a little later, then a little more later. Yes, so stillbirth. Yes, placenta is classically, you will see a placentomegaly with syphilis, which is described as a thickness more than 4 centimeters. Yes, you do see placentomegaly with CMV infections as well, but here the other features are of syphilis, right? Hydrops, yes, syphilis can cause a hydrops fetalis. So it basically can cause anemia, thrombocytopenia, and that's the reason why you see petechiae. And the anemia can cause hydrops fetalis or heart failure. Why is it not parvovirus? Because I'm sure you all remember that parvovirus can also cause hydrops. But in parvovirus infection, there is no stillbirths. It doesn't cause stillbirths, and there is no placentomegaly as well in a parvovirus infection. Right? Why is it not varicella zoster? Because varicella zoster will classically present as limb defects, not as stillbirths. So it presents as limb defects and skin scarring. Yes, and again herpes, this is not the presentation of herpes simplex as well. So it's a very characteristic of syphilis infection. So the answer here is Treponema pallidum, right? Okay. So one of your obstetric patient presents to the office complaining of severe left calf pain, and she has a swelling as well. The area is edematous, but there is no erythema. The patient undergoes a positive Homan sign. You're concerned that she has a DVT. So we're already giving you the diagnosis. Which of the following modalities would you order? So the investigation of choice is compression ultrasonography of the proximal veins, right? So you should do a compression ultrasound, and if you find it to be positive, you have to start her on anticoagulation. Only if compression ultrasonography is not conclusive, then can you go in for other techniques like MRI or venography. But initial investigation or the investigation of choice is compression ultrasound. Yes, please remember that deep vein thrombosis are more likely to happen in pregnancy, because pregnancy is a state of hypercoagulability. Yes, it is a state of hypercoagulability. Especially if a patient has underlying coagulation disorders, then this is very likely that she would present with thrombosis during pregnancy. Yes, and also the other hint that I want you to know is that, these DVTs are most in pregnancy are generally more common on the left side. So one reason you all know, that is the big gravid uterus compressing on the IVC, but that's true for the right side as well. So apart from the big gravid uterus compressing on the IVC, what is the other reason that the DVT is more common on the left side? This is because the left iliac vein, okay, the left iliac vein is being compressed by the right iliac artery. And as a result of which there is more stasis on the left side. So stasis, hypercoagulability will lead to thrombosis, which is more common on the left side. Okay. Then a 28-year-old presents to your office at 8 weeks. She has a history of diabetes since the age of 14. So she has most likely type 1 diabetes. She is already on insulin and she denies any complication. Which of the following is the most common birth defect? Yes, so gross congenital anomalies are likely to happen in overt or pre-gestational diabetes. The reason is poorly controlled glucose levels. So it is actually the hyperglycemia which is fetotoxic. Yes, and this is because of the free radical injury. So if there is hyperglycemia in the early pregnancy, in the first trimester, there will be problems with organogenesis. Now the most common as a group are cardiovascular defects followed by neural tube defects, whereas the most specific is sacral agenesis or caudal regression syndrome. Yes. So now within the cardiovascular system, the most common is ventricular septal defect, and within the cardiovascular system, the most specific is TGA. So these are some of the commonly asked questions as far as diabetes and gross anomalies are concerned. Please remember, gestational diabetes, okay, does not cause GCA, right? Because usually this kind of an insulin resistance happens later in pregnancy. By that time, the organogenesis has already happened.